Okay, so good afternoon, ladies and gentlemen. Thank you very much to the organisers for this opportunity to speak to you today on the clinical management of COVID-19. The outline of my talk, I'm going to look at the 5 whats. What works, what doesn't work, and that I must stress is based on current evidence. As we know, this field is moving very, very rapidly. So what I say is obviously taken as of today. I'm also going to deal with what's predominantly unnecessary in the management of COVID-19, what's overwhelmingly overlooked, and a couple of future prospects that hopefully we'll have access to. So I'm going to really concentrate on treatment, clinical management of COVID in the hospital setting, but I thought I would just mention a couple of interesting recent trials of treatment in the community. Now, COVID-19 clinical management and our evidence base has largely been informed by these incredible adaptive large platform trials. And the best known is, of course, the recovery trial and solidarity trial in hospitalised patients. But in the community in the UK, Chris Butler and the team at Oxford have been running the Principle platform, which is one of these open-labelled adaptive platforms, which allows various treatments to be analysed against standard of care. And in the Principle platform, they're looking specifically at the older population, i.e. those with the greatest chance of severity of disease, in the over 65s, and also those who are over 50 with comorbidities. And in the analyses that I'm going to show, they're only looking at confirmed SARS-CoV-2 PCR positive patients. In this Principle trial, the time to onset of symptoms was 6 days. And this trial looked at inhaled budesonide by a turbo inhaler at a dose of 800 micrograms twice daily for 14 days versus the standard of care, usual care without the budesonide. And the primary outcome for this study was twofold. One was time to first recovery, and you can see the Kaplan-Meier curve on the right for this. And the second was hospitalisation or death. Now, for time to recovery, there was an estimated median benefit of 2.94, 3 days, in other words, with a hazard ratio of 1.21, which was significant. And it had a probability of superiority of 0.999. And these platforms use a Bayesian statistical approach. And so for the Bayesian interval is what you're seeing, the BCIs. For hospitalisation and death, it didn't reach the superiority level, which was above 0.975 for hospitalisation or death, but there was a clear trend towards benefit. Now, one of the problems with this trial was that it was undertaken at a time when the UK went into lockdown and hospitalizations reduced dramatically. So one of the possibilities of that budesonide may not have shown an effect on hospitalization or death because of these changes. It did show secondary outcomes with earlier time to sustained recovery once recovery had occurred, and a reduction in health services and oxygen administration. So I think for people in an older age group and those with comorbidities, this is an exciting possibility to use in the armamentarium that we're building, hopefully, in community treatment. Just to say that this Principle trial platform had already shown that doxycycline in similar age group and risk factors was of no benefit in terms of its primary outcomes of time to first recovery or hospitalization and death. And it also previously shown that azithromycin also in the community was not of benefit in terms of estimated hazard ratio for death. The other interesting platform in the community is the Together Adaptive Trial platform, where participants are enrolled in Brazil. And this platform looks at slightly younger age groups. I think the median age was around 47 for both groups. And rather than an intervention versus usual care, this platform allows intervention versus a placebo. And in persons over the age of 18, who were confirmed positive for SARS-CoV-2 and were outpatients, symptomatic for less than 7 days, and who had more than one comorbidity. Fluvoxamine, a SSR inhibitor, at 100 milligrams BD versus placebo, showed a reduction in emergency room visits of over 6 hours, about 4.3%, and for admission by around 29.8% or 30%, as could be seen in the relative risk against placebo. And this had a superiority probability of over 99.5%. Now, the exact mechanism of action of the SSRIs is uncertain, but there are suggestions that it may act through the inhibition it may have an anti-inflammatory effect. Apologies, and so this is a very interesting possibility, which is just being these studies. Sorry, this slide was taken from a presentation, and we're awaiting the full publication. So I'm going to now turn to the clinical management of COVID-19 in the hospital setting. This is my hospital where I work, at Groote Hospital. And this, again, the clinical management has largely been addressed through large platform trials, particularly the recovery trial. But before we go into therapeutics, really, oxygen obviously is a type of therapy, and COVID-19, severe COVID-19 and hospitalization is predominantly a respiratory illness, as you know, and so supplemental oxygen therapy is the cornerstone of the management of patients with COVID-19. And obviously, many patients will require just lowest level of oxygen care with low volume, low FiO2s, as from a nasal prong, moving up through face masks to the non-rebreather reservoir bags, which can give about up to 15 litres. And what we're targeting is saturations of over 90% at least. We usually look actually for over 92%. Now, if patients fail standard oxygen therapy through these masks, we do now have the opportunity to give them higher oxygen flow rates, and there are two options that are relatively widely used in South Africa: high flow nasal oxygen, which we use at Groote, and CPAP. And this paper from Greg Caligaro and colleagues at Groote Hospital really looked at our outcomes from high flow nasal oxygen. Now, the benefit of high flow nasal oxygen is it reduces the anatomical dead space. It reduces the work of the lung through humidification and warming of the air, and it provides a constant FiO2 with a degree of positive expiratory end pressure. The patient wears these nasal cannulae, they're able to eat, it's much more comfortable, and it's been shown that we can make a risk of failure versus success assessment by using what's called the ROX-6 score, i.e. the SpO2 divided by the FiO2 over the respiratory rate, taken at 6 hours. And if at 6 hours of high flow nasal oxygen, the ROX-6 is below 2.2, they have a 90% probability of failure on high flow. So it helps us to triage potentially for critical care. And if the ROX-6 is above 3.7, then there's a 90% probability of success. So we found that about half of our patients in the trial, the study that we performed, which had 293 participants, we found that 52% of those participants survived to hospital discharge on high flow nasal oxygen. And particularly during the first wave, when the success rates of mechanical ventilation worldwide were being shown to be very poor, this was a very important intervention. We have about 40 high flow oxygen machines at Groote. One of the issues that patients do have a problem with is blockage of the noses, which obviously can reduce the volume getting in. And nose care is important to ensure that they're not blocked and to keep the machines running well. So CPAP obviously is another option and has similarly been found to be beneficial. In this preprint study of a randomized controlled trial of CPAP versus high flow nasal oxygen versus either the lower dose oxygen as it is in face mask or nasal prongs, they described or defined acute respiratory failure as a saturation at SpO2 of less than 94 on an FiO2 of 0.4, and their patients were much less sick, in fact, than the patients that we see. Their mean FiO2 on going onto CPAP was 0.6. Ours is usually around 0.9. So these were less sick, and their CPAP, their primary outcome versus conventional oxygen, their primary outcome was intubation or mortality within 30 days, was met and reduced by CPAP with an odds ratio of 0.72. But it wasn't driven by mortality, it was driven by reduced intubation. And in this study, they found high flow had no effect on the primary outcome, it was no better than standard oxygen. But as I say, I think these patients were very much better than the patients we see. And the other limitation of this was that it was a very high crossover. In other words, patients in each of the group, particularly those with high face mask and nasal prongs, did have small amounts of time on CPAP or high flow before randomization. So there always is a problem. CPAP is also does have a higher rate of adverse reactions, as has been found in other studies. The other important oxygenation issue we use, and I'm sure you do too, is conscious proning. And obviously proning has been used in ICU care for a long time, but in the wards we use conscious proning. And some of our patients spend almost all of the 24 hours in the prone position. And this, as you know, it improves the VQ mismatching, it reduces shunts and recruits more oxygen into the posterior lung segments and improves secretion clearance. And so this is a very important part of our oxygen therapy. So coming on to drugs, medicines. As you know, COVID-19 is an immunopathogenic disease, as are most infectious diseases, of course, whereby damage can be done both by the pathogen and by our immune response. And in the early stage, the idea is that most of the findings relate to the virus effect. But as in some patients who will progress with clinical disease to moderate to severe and then to severe, there is an increasing inflammation, and this is associated with increasing oxygen requirements, usually, as we've just been discussing, and then finally, in very severe and critical illness, respiratory distress, ARDS, and respiratory failure. And in the laboratory, you see in the viremic stage, or the viral sort of pathogenesis stage, a lymphopenia, which is common to viral infections. And then as inflammation takes over, you see increasing markers of severity of inflammation, such as the CRP, D-dimers, IL-6, etc. So just to touch on the immunopathogenesis, what's actually happening in the lung? Well, the SARS-CoV-2 predominantly infects the type 2 pneumocytes. Now that firstly decreases interferon signaling, so there's a weak interferon alpha type 1 response, which doesn't help clearance of virus. But also there's a pyroptosis, which is a very inflammatory type of programmed cell death or apoptosis, releasing inflammatory cytokines and pathogen-associated molecular patterns, PAMPs, which are recognized by resident alveolar macrophages. They're then stimulated to themselves produce inflammatory cytokines and chemokines, which recruit inflammatory cells such as monocytes, which themselves then can transfer into monocyte-derived macrophages, and particularly the M1 phenotype, which is highly pro-inflammatory, as well as T cells, Th1, CD4 cells, CD8 cells, neutrophils, and inhibition, in fact, of natural killer cell function. And at the same time, macrophage M2 recruitment can lead to fibrosis as well. In the endothelium of, in the capillary pulmonary intravascular capillaries, there is binding of the SARS-CoV-2 to the endothelial cells, and an endotheliitis occurs, and that causes leakage of, again, inflammatory cells and fluid into the alveolus, causing edema. I will come on to talk a bit about anticoagulation later, but the intravascular megakaryocytes and fibrin clots, as you know, also play a role in immunopathogenesis. So what you see is this filling up, basically, with increasing severity of the alveoli. Macroscopically on post-mortem, the lungs are heavy, edematous, and they are also show intraalveolar hemorrhage. Now, a positive feedback loop is set up with a cytokine, causing a cytokine storm, whereby there's this positive feedback, increasing cytokines through the mechanisms that I've alluded to. And these hypercytokine state then increases signaling, intracellular signaling through various pathways, including the NF-kappa beta pathway and the Janus Kinase signal transducers and activators of transcription pathways. And some of the drugs that we now use obviously target these pathways to reduce cytokine storm and reduce inflammation. And of course, corticosteroids are a centerpiece now of treatment. Steroids reduce inflammation both at the transcription level by inhibiting NF-kappa beta and therefore gene transcription, also through post-translational modification, decreasing the stability of these inflammatory cytokine mRNAs, and also by changing the survival of cells such as polymorphs, tissue macrophages, monocytes. And the recovery trial showed what is now standard of care, that dexamethasone, given at 6 milligrams daily for 10 days, improved mortality. And it was the first trial to show a drug improved mortality in COVID, as you know. And in those on invasive mechanical ventilation, they had a reduction of 36% in mortality. Those with just requiring less oxygen support, 19%. But importantly and interestingly, in relation to the budesonide in the community study, if a patient's not requiring oxygen, there was a trend towards harm by giving corticosteroids. So patients in hospital who do not require oxygen, have an oxygen requirement, do not require steroids. A meta-analysis and systematic review from Cochrane showed that overall mortality in the variety of trials we put together reduced overall all-cause mortality by about 10%. But what's the optimal dose of dexamethasone? And that's not yet known, but there are indications from some of the other studies which have shown some benefit in other immunomodulators that possibly a higher dose of dexamethasone may be beneficial. And this is now what the recovery trial is moving into, and we hope to become a site, as are a number of other places in South Africa. So one of the drugs which has shown the potential for greater immunomodulation being of benefit is tocilizumab, which is, as you know, an inhibitor of the IL-6 receptor and the soluble IL-6 receptor. So both pathways of gene activation of transcription can be modified. And the recovery trial again showed that with tocilizumab, and in these patients, almost all of them were already on steroids, and the inclusion criteria for this part of the study was that they were hospitalized patients requiring oxygen, and they had a laboratory feature of inflammation with a CRP of greater than 75. And in these patients already on steroids, the reduction in mortality rate ratio was 0.85 with significant confidence intervals. And there was also a greater probability of discharge from hospital and reduction in the need for progression progression to ventilation, and also renal support. So tocilizumab would be a very useful addition to our armamentarium. Unfortunately, tocilizumab is about 7,000 rand a shot. And so the NEMLAC COVID rapid reviews have come down on the fact that despite the reduction in death in the trials, tocilizumab is not affordable and therefore not in the public sector available. Two other treatments have also been shown more recently to be of benefit in hospitalized patients. And those include both viral targeted and immune targeted therapies. From a viral target, the REGEN-COV monoclonal combination of casirivimab and imdevimab given to patients, again, admitted to hospital, showed that in those patients that were admitted who were seronegative for SARS-CoV-2 at the time, suggesting that they may have been slightly earlier in the stage than those that were seropositive. In the seronegative group, there was a benefit from REGEN-COV, from this combination antibodies that bind to non-overlapping epitopes in the receptor binding domain, did reduce the primary outcome of death at 28 days with a ratio of 0.83 and a p-value of 0.01. So this, again, unfortunately, is an unaffordable option in our setting, but potentially, if it became affordable, that would be great. The other option which has shown benefit is the JAK inhibitor, a number of them, not tocilizumab, as we've just discussed, the IL-6 inhibitor, but Tofacitinib, the NIBs, and various other NIBs, including baricitinib. And these signal through, these are stimulated by a variety of cytokines, including IL-6, in the Tofacitinib case, and these signal through the Janus Kinase inhibitors and through the STAT pathway to stimulate transcription. And so these inhibitors, like Tofacitinib, will inhibit gene transcription. And a New England Journal study from this year, which was Pfizer funded, it must be said, of 14 days of oral JAK kinase inhibitor versus placebo, and again, most of these patients were already receiving steroids, they had a composite primary outcome of death or respiratory failure at 28 days, and that was reduced by about 37%. It wasn't powered for mortality alone. It might be that progression to respiratory failure was really driving this composite outcome, and there were no significant differences in the adverse events. So Tofacitinib is one to watch. Another JAK kinase to watch is baricitinib, this preprint article from an Eli Lilly funded double-blind placebo-controlled RCT of around 760 patients in each group, baricitinib versus placebo. Their composite primary outcome was not achieved. The confidence intervals crossed 1, but they report a 28-day all-cause mortality reduction with a hazard ratio of 0.57. But I think we really need to wait for the full article to judge this publication. Remdesivir is an antiviral which is in fairly wide use in South Africa's private system, but hasn't been shown to have an overall effect on mortality. Its maximum effects in terms of benefit really are questioned, I guess, because in this Act 1 trial, which was the first to show that remdesivir reduced the days to recover needed to recover. The proportion on low oxygen delivery was greater in the remdesivir group, and it questioned whether there was actually an effect. And indeed, the Solidarity trial, which looked at remdesivir, showed not only that there was no effect on mortality, but it didn't seem to support a reduction in the time to recovery either. So the benefit of remdesivir is still extremely uncertain, and it's not part of our guidelines. The other issue in the treatment of hospitalized patients is anticoagulation. We've seen, as I'm sure you have, many cases of severe coagulopathy, thrombosis, and severe disease. So again, just to touch briefly on the sort of pathogenesis of the issues surrounding the coagulopathy. The virus itself infects both pericytes, which surround the endothelial cells, and in the pericytes that causes the endotheliitis, the inflammation of the endothelial cells, and also the binding of the virus causes to the endothelial cells, causes an imbalance of the ACE1, ACE2 ratio with a downregulation which leads to pro-inflammation, a pro-thrombotic and a pro-apoptotic set of circumstances. Now, pyroptosis, again, this inflammatory cell program death releases pro-inflammatory cytokines, and it induces intravascular coagulation. Now, the whole milieu stimulates polymorphs, neutrophils, to excrete what's called nets, which are neutrophil extracellular traps, which are like scaffolds which bind various cells, including platelets, red blood cells, and white cells. It stimulates factor 11 and generates thrombin and fibrin. And in addition to fibrinolysis being reduced in COVID-19, this leads to the increase in D-dimers that we see and the coagulopathy, the CAHA, which translates to thrombosis, both of deep veins and in the intracerebral circulation, the myocardium, myocardial circulation, and the lungs. So we anticoagulate patients, and there's a big question mark about whether we should be therapeutically anticoagulating or prophylactically anticoagulating. And this recent publication, which combined 3 trials, the REMAP-CAP, the ACTIVE-4A, and the ATTACK trials on a single platform with similar protocols, has given us some understanding, both in critically ill patients and in those that are not critically ill. So in the critically ill patients, which is really defined as those that require ICU care, because we're pragmatic, and in South Africa, that doesn't just mean ICU, because we're performing high flow nasal oxygen on the open ward, which would be critically define a critically ill person. in terms of therapeutic versus prophylactic, in critically ill patients, there's no evidence that there is a benefit of therapeutic anticoagulation over prophylactic anticoagulation, and this was judged in this study by the organ support-free days, which you can see in the right-hand figure with red and blue. So the organ support, the blue is better than red. You have a greater number of organ-free support days, and there really wasn't a significant difference. But in secondary outcomes, there was more major bleeding than in the therapeutic than the prophylactic. The Inspiration trial has also shown us that the actual dose, standard dose of prophylactic thromboprophylaxis with enoxaparin at 40 milligrams daily is of equal benefit as is intermediate dosing, which some people are using, but there's no need for that. In terms of the anticoagulation for the non-critically ill patient, this is a bit more confusing, because although there was shown to be a significant benefit from therapeutic anticoagulation versus from prophylactic anticoagulation, if you look at the confidence intervals, and these were, in this trial, there was stratification by D-dimer levels in the groups. So in high D-dimer level, greater than twice upper limit of normal, there was benefit, but the confidence interval actually touched 1. So there is a question mark, I think, still over this trial, but it suggests that in the non-critically ill patient, that there may be a slight benefit of therapeutic anticoagulation over prophylactic. Saying that, at present, at Schuur, we generally use prophylactic anticoagulation, as I said, because of this real question mark over the confidence intervals. Apologies, I got the wrong way. So what doesn't work based on current evidence? Well, I'm afraid ivermectin on the current evidence does not have evidence for benefit either in preventing or treating COVID-19. One of the big prevention trials was, again, the Together network, which didn't show any benefit. And the treatment trials, as you know, have been mired in controversy, including the fraudulent trial from Egypt, which had to be removed. Very interesting, I would point you towards Andy Parish's publication with colleagues from NEMLAC in the SAMJ this week, which looks at many of the issues around ivermectin and the reporting of ivermectin trials and how this has fueled some of the concern. I know that ivermectin is widely used in South Africa, but there is no current evidence of its benefit, and really it shouldn't be. Other things that don't work in the hospital setting, we know about remdesivir. Again, the Solidarity trial showed that hydroxychloroquine, lopinavir, ritonavir, and interferon had no benefit on mortality. And the Recovery trial has shown also that aspirin and colchicine, azithromycin, convalescent plasma, hydroxychloroquine, lopinavir, ritonavir, again, had no benefit in hospital, and they are not part of our protocols. The fruit and nuts and vegetable issues in terms of nutrients and micronutrients, clearly nutrients and micronutrients play a role in our immune system. What is extremely unclear is whether additional zinc or niacin or whatever you like to choose has any impact on outcomes in COVID-19. And in fact, in terms of vitamin C, our NEMLAC review of studies recommended against the use of vitamin C with no benefit of evidence. You can see the forest plot with the confidence intervals crossing 1. And also vitamin D. The vitamin D is actually a negative acute phase reactant. So the more severe your COVID, the more likely, the lower your the lower your vitamin D level is likely to be. And there's no good evidence that either in prophylactic or in treatment. There was one very small treatment study from Spain with major methodological concerns. There is not enough evidence from the NICE recommendations for the use of vitamin D. So again, I think there are some very interesting hypotheses there out there, but the proof for evidence is not there yet. So the fourth what is predominantly unnecessary? Well, antibiotics, I'm afraid, particularly at first presentation. So despite a pooled prevalence of about 7% of people with COVID having bacterial co-infection, in the ISARIC database, over 80% of people were receiving an antibiotic, and predominantly empirically when they're given. In our practice, patients who are suspected COVID or proven COVID on admission, and all antibiotics are stopped. Yes, there is a place for antibiotics in secondary infection, in hospital-acquired infections, in those that are prolonged courses. The problem is that when you empirically treat with broad-spectrum antibiotics on admission, you are selecting out resistant bacteria, which then come back to haunt you and the patient in the later course of their illness. And just looking at different classes, there's no information from Africa, but broad spectrum concerning antibiotics are being misused in COVID-19. What is overwhelmingly overlooked is the psychological health and our ability to manage mental health in hospitalized patients. And I'm grateful to Jackie Hall for these following slides. This is an extreme problem, and we are overlooking it, and we are not equipped really to deal with it. And what we need, and what Jackie has shown, is that actually being proactive and being in the wards, looking at patients and really helping them in a proactive way is really critical. Psychological first aid is this concept that the WHO suggests is required in people exposed to a traumatic event. It is extremely traumatic to be hospitalized with COVID, particularly in high care units. And it's a practical way of providing support. In terms of the literature on mental health, the majority of COVID inpatients were experiencing mental health disturbances. The main problems are anxiety and fear. And really, the issues of depression, anxiety and fear and post-traumatic stress disorder cannot be underestimated, not only, of course, in our patients, but also in ourselves. So at Schuur, Jackie, who's shown here, has really led the community liaison almost single-handedly. And it depends, of course, at the level of psychological input needed. We are using quite a lot of olanzapine in patients with severe anxiety. And of course, antidepressants and other things are necessary. But actually, the most important thing is just being there for the patients, touching them. Patient the other day said that was actually the most important thing that had happened to him all day, that somebody had just touched him. In the first wave, we didn't touch anybody. Now, I think we know better, but the psychological support is very, very necessary. Just a couple of future prospects for treatment. Artesunate is the subject or one of the drugs of the new Solidarity trial. In your top left-hand corner, this is a depiction of those neutrophil nets that I was mentioning. When a neutrophil, when the pathogen is encountered with our immune cells, there's respiratory burst, which leads to high hydrogen peroxide levels, and polymorphs migrate, as can be shown in the right-hand panel, towards the high concentrations of hydrogen peroxide, and their activation is shown in red in the cell. If you inhibit hydrogen peroxide, if you inhibit the action of hydrogen peroxide, the cell doesn't migrate. And then in very high concentrations of hydrogen peroxide, which you would get around the area of the respiratory burst, when that polymorph gets there, there is a switch to neutrophil attack mode, which is shown in the red on the right-hand most panel of the top right-hand corner. The artemisinin are known to inhibit hydrogen peroxide burst, and that's shown in the bottom left corner. And so the artemisinin are now an option. And in the rodent acute lung injury model, the dihydroartemisinin, another type of artemisinin inhibited sepsis-induced polymorph influx. And so this is a possibility and is now being trialed in the Solidarity trial. In a recovery trial, empagliflozin, can never pronounce this, is a member of the next, hopefully the next set of drugs to be tested. This is an inhibitor of the sodium and glucose transporter 2, has effects on glucose metabolism, but also much greater pleomorphic effects on immunity. I'm not going to go into long COVID because this is just not long enough a webinar, and it's a massive topic in itself. But I point you towards this extremely good Nature Medicine review and the importance of the holistic viewpoint of the patient with long COVID. And again, the real importance of the neuropsychiatric input for these patients. So in summary, oxygen in clinical management, in the clinical management of COVID in the community, I think at present there's a case for inhaled budesonide, and the SSRI fluvoxamine is of great interest. In the hospital patient, oxygen is the mainstay, but we've seen that there are also possibilities in addition to dexamethasone, unfortunately, possibilities that are unaffordable for us, such as tocilizumab and the JAK kinase inhibitors, baricitinib and tofacitinib. There are other investigational immunomodulators that will come through, and then investigational antivirals. And unfortunately, again, access to some of these is going to be limited. So in closing, I'd like to acknowledge the patients who it's really an honor to serve. All my colleagues at Groote and UC2 who've shared this extraordinary time, and to Jackie and Sean for sharing some of their slides. And then lastly, to the Scientists Collective and the COVID feed group throughout South Africa who have shared the experience and made the last 18 months more tolerable. So thank you very much.